I'm a physician at the Division of Allergy and Clinical Immunology at the Children's Hospital, and I'll try to connect between our word of allergy, mainly food allergies, and your word, mainly eczema, especially looking at factors associated with the development of food allergies. These are my disclosures. And I'll start by outlining the background, looking at the prevalence of food allergy. I don't know if you're aware, but food allergy is increasing in prevalence substantially. And while in the past less than 0.2% of the population had food allergy, we're speaking now about 2% of children in Canada or the US who have peanut allergy, and about 6 to 8% of all children having any kind of food allergy. So if that food allergy is increasing in prevalence, there are some factors in the environment, probably, or the lifestyle habits that are responsible for that increase. And we are going to review some of these, especially looking at our case control study, discuss a few knowledge gaps and future directions. So first of all, we need to understand what we are discussing when we are discussing food allergy. Please do not hesitate to ask me any questions if you have. I have a tendency to speak very fast. So when we speak about adverse reactions to foods, most of the reactions are not mediated by the immune system. And these reactions that are not mediated by the immune system are called intolerances, and they're not life-threatening. So it's very important to differentiate, because when you do studies, many people will report that they have food allergies, but most of the time they will be speaking about intolerances. And if you speak about intolerances, some of them are mediated by enzymatic deficiencies like lactose intolerance because of lack of the lactase enzyme. Toxic effect, like having a salmonella toxin or staph toxin and having food poisoning. Again, it's not mediated by the immune system. Pharmacological effects, for example, having headaches after or palpitations after ingesting foods rich with caffeine or monosodium glutamate. Undefined reactions. And then you have immune-mediated reaction. It's very important to differentiate between the two, because the immune-mediated reactions can be life-threatening, and they are differentiated into non-IG-mediated reactions and IG-mediated reactions. And I'm going to speak specifically on the IG-mediated reactions, because these can result in what we call anaphylaxis. So anaphylaxis is an allergic reaction that occurs usually within 2 hours after ingestion of the food and could be life-threatening, and it's mediated by IgE. So there's extreme importance to diagnose it correctly. So this is a child, a neonate, that came to our department with anaphylaxis after eating banana. What are the classical symptoms of presentation? So it can involve different systems, and once you have two systems involved in the presentation, you speak about anaphylaxis. So if you speak about the skin, you'll have hives, flushing, angioedema, or swelling of subcutaneous tissue. If you speak about the respiratory system, you'll have wheezing, problems breathing, stridor, GI symptoms like diarrhea, abdominal pain, but unlike intolerances, they will always appear, and they appear immediately after you eat the food. You can have cardiovascular symptoms, drop of blood pressure, and shock. So if you have two systems involved, you speak about anaphylaxis. Then you can have other immune-mediated symptoms due to foods, but these are not usually life-threatening. Celiac disease, for example, is an immune-mediated reaction. We know that about 1 out of 100 will have celiac disease, but this is more of a chronic disease, although mediated by the immune system, will not cause an immediate threat to life. How do you diagnose food allergy? So when you think about food allergy, everybody comes up to the clinic and speaks about skin testing. So you need to know that all of these testing are confirmatory testing, and they're useless unless you have a supportive history. So skin tests, they can be done already at the age of 3 months. If you use topical steroids, you can render the skin test less positive. And you need to know that skin tests are false positive in about 50% of cases. So a mother who comes to my clinic and tells me, I want to know if my child is allergic to peanut, let's do a skin test, I tell her immediately no, because unless he has a history, it's like, throwing a dice and gambling, because 50% will be false positive. So there's no point in complicating his life unless he had a history. If he has a history of a reaction to, for example, peanut, using a skin test that is positive will confirm the diagnosis, but unless there is a history, it's useless. Same thing for IgE, specific IgE levels. So what we do here, we have, for example, a membrane. Could be peanut, milk, any food allergen. If somebody is allergic to that food, you'll have an IgE to that food. You put the serum with a membrane, there is binding to the antigen, and then you use the antibody that marks the antibody that bound. If there's binding, it means that there's an IgE against that food, and you can quantify the levels of IgE against a specific food and determine threshold levels to predict the likelihood that somebody will react. However, again, if there's no history of a reaction, studies suggest that about 90% of individuals in the population can have very high levels of specific IgE, but will still be able to tolerate the food. And then we have a gold standard to diagnose food allergy, which is the food challenges, which can be open, single blind, or double blind. Because you'll be very surprised to see how many people react to peanuts once they hear that they are eating peanut. So we really need the placebo-controlled test. So diagnosis of food allergies, in conclusion, relies on careful history, supplemented by confirmatory testing, which will be the skin test or IgE. So if the prevalence of food allergy is increasing, and if yes, why? So that's the main question. So many studies in the worldwide have shown that the prevalence has increased during the last decade. We in Montreal have conducted 2 studies, 2003, 2009, especially looking at peanut allergy, that showed that about 1.6% of school-age children have peanut allergy. The prevalence remained more or less stable during the last 5 years. But when we did a meta-analysis looking at worldwide studies, we showed that the prevalence of food allergy has increased substantially, about 0.6%, and especially in non-English speaking countries. So while in English speaking countries, the prevalence of food allergy having reached a plateau, in non-English speaking countries, the prevalence is continuing to increase. For example, in China, they did food challenges for children 1 year old at interval of 10 years, and they showed that the prevalence of food allergy in general and peanut allergy in particular increased about 10-fold. So if it's increasing in such a short period of time, it means that it's not the genes that are changing in such a short period of time. So you need to look at the environment. Something that we are doing in the environment, some kind of lifestyle habit is causing or is associated with an increase of prevalence. And potentially this is a modifiable risk factor that can be used to decrease the prevalence of food allergy. So this could be something in the atopic background, something in the way you introduce the food, or in the way you live, let's say living in a farm, small-sized family, more infections, less infections. All these factors were suggested to be associated with the development of food allergies. So we did a case control study. We did a telephone survey, across Canada telephone survey, in which we contacted households and asked whether anybody in the household was diagnosed with food allergy. If they said yes, we were not satisfied with that. We queried about the presence of symptoms and whether any testing was done, because many people report that they have food allergy, but most of the time it will be an intolerance. Once they said that there was a food allergy and it was confirmed, we queried about the presence of demographic factors, lifestyle habits, and atopy. So whether they had eczema, food allergies, or hay fever or asthma. We asked specifically about age of introduction of specific foods. I don't know if you know, but in the past, mothers or parents were advised to wait till the age of 3 years till you introduce potentially allergenic foods like peanut or shellfish, because the assumption was that the immune system is not mature enough to deal with these allergens. Let's wait till they're 3 years old and then introduce the allergen. This has substantially changed because studies, for example, in the UK, have showed that mothers that restricted or introduced peanut allergy only after the age of 3 years increased the risk of peanut allergies in the offspring tenfold. So being too protective was not too good, and the assumption today is that there's that tolerance period in early life in which you can introduce a food and in that way induce tolerance instead of allergy. So we asked specifically at what age was the food introduced. We asked also about living in a farm, exposure to farm animals, vaccination, because you know that there's that talking about the hygiene hypothesis. So basically saying the dirtier is the better, because we don't expose our immune system enough to bacteria and infections. Our immune system is skewed towards the allergic direction. So we asked about all these things. So these are our cases and controls. So we had about 500 cases with food allergies, and we have about 5,000 controls. You see that the cases and controls are comparable to regarding many demographic aspects. So if we looked at all food allergies, so having any food allergy compared to controls, you can see that there are many factors associated. Some of them are demographics, so I will discuss mainly the eczema factor, but you can see that males have less food allergy, and studies suggest that estrogens increase the releasability of mast cells that are the main cells to play a role in the development of a food allergic reaction. You can see that after the age of 5, you have less food allergies, or the risk for food allergy is lower, because we know that some of these food allergies resolve over time. So, for example, about 60% of those with egg allergy in early life will outgrow their allergy. So it's not surprising that with time, or with increasing age, you have less food allergy. High income associated with more food allergy, so that goes with a hygiene hypothesis. So high income is associated with more vaccination, more smaller family size, restricted infection exposure, and this is suggested to skew our immune system towards the allergic direction. So going with the hygiene hypothesis. But you see on the other side that if you have severe infection that requires hospitalizations, you are more likely, not less likely, to have food allergy. I want to focus mainly on the eczema. And the new thing about our study that we looked at eczema in the early life, 2 years of life compared to eczema later. And we showed that specifically eczema in the first 2 years of life is associated with the development of food allergy. And if you look at specific foods, because we were querying specifically on the presence of the main 9 food allergies, so milk, egg, peanut, tree nut, fish, shellfish, wheat, sesame, and soy, you can see that eczema in early childhood is associated specifically with egg allergy, peanut allergy, and tree nut allergy. We think that milk allergy is not specifically associated with the eczema because milk is introduced so early in life, even before eczema develops. So what is the association between eczema and food allergy? I guess you all heard about the filaggrin gene. So we know today that eczema, atopic dermatitis, the main genetic factor associated with the development of atopic dermatitis is the presence of mutation in filaggrin gene. What is filaggrin? So filaggrin is processed by different enzymes in the cell. And once it's processed, it's associated with a developmental change in the keratinocyte, making it more flat and generating what we call the natural moisturizing factor in the skin that helps keep the skin barrier intact and reduce the pH of the skin. All these factors are associated with intact skin barrier. So when you don't have filaggrin functioning appropriately, you won't have an intact skin barrier. If you don't have an intact skin barrier, what happens is that food that you are exposed through the skin are introduced to your system too easily, not going through the natural tolerizing mechanism that you should have. So basically, we speak today about a theory suggesting that when food is introduced early through the mouth, it induces tolerance. But when it is introduced too late and through the skin, it induces allergy. So especially in children who have an impaired skin barrier, the introduction through the skin leads to the development of food allergy. And we know that there are 3 types of reactions to food in those with atopic dermatitis or eczema. One of them is the immediate type IG reaction. These are the reactions we are discussing now. So immediately, somebody with eczema will have hives and problems breathing or diarrhea when he eats milk or egg. There could be itchiness or pruritus after ingestion of specific foods, or there could be an exacerbation of atopic dermatitis 6 to 48 hours, so not an immediate reaction, IG-mediated, but a late reaction associated with the exacerbation of atopic dermatitis. But if you do look at the food challenges, which is the gold standard to diagnose immediate type of food allergy, you can see that the rate of food allergies in those with eczema is much higher compared to the general population. So if we speak about 6% of children in the general population with milk, peanut, or egg allergy, we can speak about 30% of those with eczema. And another study that contributes to that advanced hypothesis about the role of eczema in food allergy is a study done by Filterman in 2004. So what he did, he took 11 children with eczema, and what happens is that we have many referrals from dermatology telling us, you know, the eczema is exacerbated by exposure to egg or milk. Could you please assess that? And if it's associated, please eliminate these foods from the diet. So first of all, we cannot really confirm the presence of eczema exacerbated by food by skin testing, because skin testing, as I told you before, confirm only the presence of an IG-mediated reaction, and these exacerbation of eczema are late reactions. But studies looking at elimination diet in those with exacerbation of eczema reveal that when you restrict the diet of children in those with eczema, you increase the risk of having a type 1 allergy, the life-threatening type of reaction. So I'm always telling the parents there's a balance here. Okay, the eczema will be better if you eliminate the food from the diet, but on the other hand, you'll have a much increased risk of an IG-mediated reaction. In this study, Filterman looked at 11 children with milk-exacerbated eczema. He eliminated eczema from the diet, and a few months later on, they all had a positive double-blind placebo-controlled challenge to milk. Again, showing you that there's a balance. If you eliminate specific food from a diet, you might increase the risk of an IG-mediated reaction because the tolerance is dependent on constant exposure to the food. Another thing other studies that, again, contribute to the shift in our thinking, a study done by Gideon Lack and Dutoit in UK, compared children in UK and Israel looking at peanut allergy and other food allergies. They looked at different factors in the environment, and they showed that the only difference was that in Israel they consumed peanut at a much earlier age, 4 to 6 months, compared to the UK, and the rate of peanut allergy in Israel was 10-fold lower. Again, suggesting that in order to develop tolerance, you need to be exposed to the food at an early age. Other studies suggest the same thing about milk allergy. So again, so breastfeeding is very good, but if you want to avoid cow milk allergy, studies suggest that you need to introduce cow milk base formula at an early age, and probably earlier than 3 months of age. And the same thing holds true for egg allergy. So those that consumed egg at an earlier age had a lower risk of having egg allergy. And this is basically summarizing what we call the dual hypothesis. So low-dose exposure to environmental foods on tabletops, hands, and dust through skin activates Langerhans cells and leads to Th2 or allergic type of reactions. But early high-dose oral consumption induces tolerance. And we looked specifically in filaggrin mutations in those with peanut allergy, and we indeed showed that in those with peanut allergy, irrespective of other factors, the likelihood of having mutation in the filaggrin gene is 3 to 5 folds higher. We collaborated here in the group in Ireland. Just a few words about the hygiene hypothesis. So all these parents now coming and saying, well, there are some factors suggesting the dirtier is the better, basically. So exposure to bacteria will skew your immune system away from the allergic direction. However, this theory was very simplified, and although in animal models, certain bacterial components may repress the development of allergies, studies in humans suggest that there is no correlation between the increase in allergic disorders and decrease in infection with pathogenic organisms. So it's not that, avoidance of vaccination with mumps, measles, or rubella will protect you against food allergy. And personally speaking, I would prefer my child to have peanut allergy than, having measles. It led to unfortunate speculations that vaccination would increase the risk of allergies. And the updated hypothesis is the dietary factors and the interaction with commensal, the good bacteria in the gut, early in life may be protective against food allergy. So in conclusion, atopy, eczema, lifestyle habits, when do you introduce the food, demographics, age and sex, and genes all interact in the development of food allergy. Food allergy is common in Canadians in the US wide-wise, and it's increasing in prevalence in other countries, up to 8% of children. Timing of food introduction, presence of eczema, and lifestyle habits may affect the development of food allergies. And randomized controlled trials are required to establish the role of environmental factors and eczema specifically in the development of food allergies. So thank you so much. These are our supporters. I'll be happy to answer any questions.
Any questions now? So I have one question.
Okay, sure.
You mentioned that non-immune cells, you have to divide the allergies into immune cells and non-immune cells.
No, I didn't divide allergy. I divided immune reactions to foods, to immune-mediated and non-immune-mediated.
I didn't quite understand what is non-immune cell mediated.
So it means that the reactions is mediated by other factors. For example, if you lack lactase, you will not be able to degrade lactose in your gut, and you will have accumulation of lactose in the gut, which will be degraded by bacteria to specific gases and products, which will cause abdominal pain, bloating, and vomiting. But this is not a life-threatening reaction. This is an intolerance because it's not mediated by the immune cells.
And at what early stage a child can be detected for penis?
What, sorry?
At what early stage a child can be identified for a peanut allergy?
Almost any age. Once he had a reaction, at the age of 3 months, the skin test is already positive. So I would say once they are introduced to solids, it's for a month, 4 to 6 months, depending if it's European or US recommendations, you can already assess.
And with the egg allergy, see, in most of the vaccination, egg albumin is introduced as an adjuvant, right?
Not necessarily. So in MMR, you don't have egg. It's a false idea. So people in the past thought that because MMR is grown on chicken embryos, it contains egg allergen, which is not true. All those that reacted to MMR is reacted to gelatin and not to the egg. So MMR is safe in those with egg allergy. Influenza vaccine, recently the guidelines have been changed. And today we know that the quantity of egg protein is very minimal, so it's safe for those with egg allergy. The only exception is yellow fever that is on egg, and this is the only one that is contraindicated in those with severe egg allergy.
So my question is, with whatever the vaccine they are using the egg albumin or egg
it's just protein. The influenza, and it's small quantities, so it's not
small quantities.
Yeah,
so
minimal.
Don't you think that is inducing the tolerance in the kids, and in the later stages they don't develop the allergy for egg?
Why for the vaccine you mean, or
so through vaccine the albumin is given to the kids.
Yeah.
So in the later stage, do you think those kids are develop the tolerance for egg protein?
So you need basically to introduce the food through the mouth, the protein through the mouth, not through the vaccine and not through the skin. The problem is when the first introduction of the food is through the skin, like especially in children with eczema, because the skin does not possess the same tolerizing mechanism from the gut. So the best way to introduce the food is through the mouth, and probably at an early stage. So the vaccine won't be a form of introduction that is recommended.
Thank you.